So yes, I'll be talking about Polycythemia Vera in 2025, state-of-the-art standard of care. Okay, these are my disclosures. So personalized management in PV, as for any disorder really, crucially first establish the diagnosis, carry out risk stratification, personalized therapy in order to predict risk of complications, give the patient a clear picture about their disease and to select the best treatment. So the diagnostic criteria really simplified since the discovery of the JAK2 mutation 20 years ago now, really based on an elevated hemoglobin and presence of the JAK2 mutation. So pretty straightforward, minor criteria of a suppressed EPO level. Whether a bone marrow is required is a little bit debatable. Certainly not in all cases it's required, but can be helpful to look for early signs of fibrosis or in cases where there is iron deficiency, so it could be a kind of masked PV type of picture. The other thing to point out is a slight difference in the hemoglobin and hematocrit cutoffs between the British and ICC WHO criteria. Okay, so following a diagnosis of PV, is there an impact on life expectancy? So it seems pretty clear now that there probably is an impact on life expectancy. And here's some kind of standardized mortality curve showing the impact of a diagnosis of PV. You know, that was pretty terrifying, I think, if you were diagnosed at a youngish age to see a median survival of 15 years. So always worth bearing that in mind because people Google this and they find it after a diagnosis. So this is why risk stratification is quite important because you can probably help predict these outcomes. What do people die of? Of course, a whole range of different diseases, but two main groups, thrombotic complications and risk of progression to more advanced hematological malignancies. So what are the key factors for risk stratification? Well, age and thrombosis are the kind of canonical, very well-established criteria. Slightly different cutoffs can be used for age, depending on which criteria you use. That could be 60 or 65. But people who are younger and have not had a history of a vascular event or thrombosis relating to the disease are classically called low-risk patients. But it's a little bit more complicated because there's a whole range of additional factors that can predict increased risk in these so-called low-risk patients, such as cardiovascular risk factors, high white count, and so on. And I'll pick out some of these as we go along. In particular, molecular factors can be important, and measuring the JAK2 allele burden is one particular thing that's really moved through to routine clinical practice these days. And as shown in this slide, if you have a JAK2 allele fraction over 50%, it's a strong predictor of increased risk of venous thromboses on the y-axis here, but not interestingly arterial events. High JAK2 allele burden is also a risk factor for progression to secondary myelofibrosis and generally associates with more proliferative and slightly more aggressive disease features. Additional mutation profiling can also have a role. It's a little bit complicated and less well established, I think, than in myelofibrosis because different studies kind of highlight different mutations. But in selected patients, there's certainly a role for carrying out next generation sequencing. And if you find an additional mutation, then it's worth kind of looking up some of these risk scores. Here in this study, SRSF2 was a key risk factor, although reports have highlighted IDH, RUNX, U2AF1. The MAGIC study highlighted presence of ASXL1 as a risk factor. And this nice study from the French group recently highlighted the role of additional mutation profiling to help predict the risk of arterial thrombosis, so particularly TET2, DNMT3A, mutations predicting increased risk of arterial thrombosis, irrespective of the MPN diagnosis. So it's worth noting that even in these so-called low-risk patients, their risk of a vascular event or thrombosis is significantly higher than the general population. So low risk doesn't mean no risk, and there are certainly some low risk patients who you should consider for treatment according to those risk factors as outlined before. So what are the aims of treatment in PV? It's outlined on this slide. I think largely it's relating to preventing the risk of thrombosis, reducing the risk of transformation, improving symptoms and quality of life. But of course, managing the emotional impact of a diagnosis, managing treatment toxicities, and managing unusual and special situations is important. I'm not going to talk about this one today because we've only got 15 minutes. Okay, so once you've risk stratified and you think a patient is low risk, how should those patients be managed? Well, all patients should have a target hematocrit of less than 0.45, low-dose aspirin, and less contraindicated for all patients, and careful management of cardiovascular risk factors. And as I've talked about already, consider cytoreductive therapy in so-called low-risk, conventional low-risk patients, but with additional features predicting a high-risk disease course. So evidence for the use of aspirin, that's quite from a fairly old study now, randomized study, very clear-cut results showing benefit for aspirin in the composite event-free survival endpoint. Still some questions around aspirin, what same dose for everyone? Should you increase the dose in people with aspirin resistance? What about people with extreme thrombocytosis? What do you do in the setting of intolerance? Is clopidogrel a reasonable alternative? I think there's a few things that we could discuss at the end if we've got time. The CYTO-PV study nicely established the importance of controlling the hematocrit rigorously below 0.45 in order to reduce the risk of disease complications. Here, I think there's still a question of whether, controlling the hematocrit with cytoreduction and therefore also controlling the other counts versus controlling the hematocrit with venesection, or there's other therapies coming through, of course, which are now going to very selectively control the hematocrit. This remains quite an important question, I think. Do you need to control all the counts, or is the hematocrit the absolute key target of the treatment? If you do treat low-risk PV, probably Ropeg interferon, if not contraindicated, or Pegasus is the right treatment. This was a nice study from Tiziana Barboui and colleagues, randomized low-risk patients between Ropeg and standard treatment with venesection to control the hematocrit, and you can see the treatment response higher, lower risk of disease progression, a lower number of venesections, as you would expect, on cytoreduction, and an increased rate of molecular responses. We'll come back to that at the end. Okay, on to high-risk PV. There are other treatments, but largely this is a decision as to whether you start a patient on hydroxycarbamide or interferon. Generally, I think hydroxycarbamide remains the most commonly used first-line treatment, but interferon is getting used more and more frequently. And it's interesting because they're two agents with really completely different profiles. One's oral, one's injected, quite different side effect profile. So weighing that up can be sometimes quite nuanced, particularly in older patient groups. So what's the evidence for the use of hydroxycarbamide in patients with polycythemia vera? Well, there isn't randomized control trial data to show hydroxycarbamide is beneficial compared to a control arm. There is in essential thrombocythemia, so it's often kind of extrapolated from ET that the benefit is likely to be the same in polycythemia vera. There has been direct randomized controlled trial comparison of hydroxycarbamide versus interferon. So there was the MPD-RC112 study led by Ron Hoffman, John Mascarenhas. This included both ET and PV patients. At 1 year, the rates of complete hematological remission, the same overall response rate, possibly a little bit higher with pegylated interferon. With Ropeg, again, a similar story, complete hematological remission rates, pretty similar, possibly some benefit for Ropeg. Molecular response rates really dramatically improved, with Ropeg compared to hydroxycarbamide, and we'll come back to that. Adverse events, interestingly, quite similar between the two groups, which, perhaps is a little bit surprising, because interferon often is associated with some side effects in hydroxycarbamide. I would say in my day-to-day practice, less so. Event-free survival with longer-term follow-up appears to be superior with Ropeg interferon as the frontline treatment compared to the control arm from this study. And hydroxycarbamide, worth bearing in mind, can potentially have long-term risks. In fact, this question of leukemic risk still comes up, but to my mind, the data is pretty reassuring for hydroxycarbamide in terms of when it's only used as a single agent. It's pretty reassuring in terms of risk of leukemic progression. Hydroxycarbamide does have side effects, primarily mucocutaneous, worth not forgetting risk of pneumonitis, and about 5% of patients end up needing to stop treatment due to side effects in the largest study that's reported this. So in patients that develop side effects or develop resistance to the treatment, so there are quite clear-cut criteria for defining resistance to hydroxycarbamide. I'm not going to read through it all, but essentially it is failure to control the blood counts or other disease features despite optimization of the dose of hydroxycarbamide, and it's outlined very clearly in these ELN criteria. And people who meet the criteria, bona fide, quite strict criteria for resistance, really have quite adverse outcomes compared to those that don't, as shown here. Increased risk of transformation, reduced overall survival. So they're definitely a high-risk group. So what to do with those patients? Well, if they received first-line hydroxycarbamide, you can certainly think about switching over to interferon or vice versa. But the key second-line treatment to think about in PV is ruxolitinib. So what's the evidence base for doing that? Well, I think the most robust study comes from Claire Harrison, the MAGIC PV kind of consortium of investigators. This took patients with high-risk PV, intolerant or resistant to hydroxy, and randomized with long follow-up, no crossover, best available therapy versus Ruxo. And a very clear-cut result in terms of hematological control, superior for ruxolitinib versus best available therapy. But I think this really, the killer data in this study, improved event-free survival with ruxolitinib. So it's really the go-to drug for patients with hydroxycarbamide intolerant resistant PV. I think that's pretty firmly established now. The other important finding, or one of the many important findings from the study, was that achievement of complete hematological remission is a really crucial goal. I alluded to this earlier, but complete hematological remission requires control of all the different blood parameters. And irrespective of whether that was achieved with Ruxo or other treatment, the event-free survival was superior in persons that achieved complete hematological remission. There's a number of commercial studies that have also tested Ruxo in this setting. I've just picked out one. I'm not going to go through it in detail, but I wanted to particularly point out this is also a randomized study, also associated with improved hematological control with Ruxo versus best available therapy. But symptoms is really key. And this was a nice study, as the MAGIC study. And all studies have shown with Ruxo versus BAT in this setting, vastly improved symptom control with ruxolitinib versus best available therapy. Okay, so the final thing I want to talk about is molecular response as a treatment goal. This was another important contribution of the MAGIC study. So when you've got people with PV on treatment, a key goal we've established on that slide is complete hematological remission, but is molecular response also a treatment goal? So in the MAGIC PV study, molecular response defined as a relative 50% reduction in the variant allele frequency, irrespective of the treatment, was associated with markedly improved event-free survival. It was the first study really to definitively show this. Ruxo was more effective than best available therapy at achieving molecular remission. And also in the PROUD-PV study. Interestingly, early on, hydroxycarbamide showing slightly increased rates of molecular response. And it's worth just noting some of the detail as to how that molecular response is defined here. So in people with a high VAF, it's a much more subtle reduction in the variant allele frequency. But with time, ROPEG clearly superior to the control arm. And again, in the first line setting, remember MAGIC was the second line setting. In the first line setting, achievement of a molecular remission also associated with improved event-free survival. So I think the field has really moved on in the last few years to really firmly establish complete hematological remission is an important treatment goal, and molecular remission is probably also an important treatment goal. I think what's a little bit unclear is if you've achieved a complete hematological remission, should you carry on pushing? But similar to the previous discussion with regards to interferon dosing, should you carry on pushing the dose to try and achieve a molecular remission in someone where you've completely normalized their blood counts? I think that remains unclear. And the final slide, just to give a shout out for the Mithridate study. This is being run in the UK and France, really asking the question, given the success of ruxolitinib as a second-line treatment, what about bringing this to the front line in patients with high-risk PV? The other important question this study is asking is a direct comparison of physician choice of interferon versus ruxolitinib to give us a sense of which of those two drugs might be the best first-line treatment option. So thank you very much.
Actually, I would also like to thank the organizers for inviting me to give you a little bit more insight on novel therapies in PV with a focus on the clinical trials. Here are my disclosures. So what are potential targets in polycythemia vera? And as you can see on the left side, the picture is actually not that crowded. So we are more used to more targets that we can find for myelofibrosis, but still there are some mechanisms which are currently tested in clinical trials. So I want to talk about influencing the iron metabolism. There are several drugs which are currently in clinical trials. HDAC inhibition, LSD1 inhibition, and some other potential ideas which I'm going to mention at the end of my talk. So first of all, let's start with the new drugs influencing iron metabolism in PV. This is a mechanism that is actually focusing on better disease control and avoidance of iron deficiency-related symptoms. So the influence on disease progression is not actually quite clear in this setting yet. So what does this make feasible for PV? I don't have to go into much detail in telling you that in polycythemia vera, JAK2 mutations result in a constitutively active signaling in the absence of EPO, and on the right there is the rationale for the hepcidin. So the central role of hepcidin in regulation of iron metabolism is shown here. And in PV, actually, everything is almost the other way around. So if we, at the top of this slide, you can see the hepcidin function in a normal setting, in an iron deficiency hypoxia setting, and also in the PV setting. And hepcidin functions normally as a negative regulator at the basolateral surface of the gut. So it leads to the fact that ferroportin exports iron from enterocytes into the circulation. And in PV, on the other side here of the slide, despite this hepcidin suppression, hypoxia is diminished by this erythrocytosis, and this is preventing recovery from iron deficiency. So here's, and that is the situation of hepcidin in PV. Actually, normally hepcidin expression is enhanced by inflammation and suppressed by erythropoiesis, but in PV we have opposing factors because we have both. We have highlighted erythropoiesis, and on the other hand we have high inflammation. So this actually leads to expanded erythropoiesis, and phlebotomies lead to iron deficiency and inhibit hepcidin, and in contrast the inflammatory cytokines stimulate the hepcidin. So this there is some kind of a mixed picture here in the PV situation. But there have been a series of experiments of hepcidin manipulation in PV, and there has been evidence that increasing hepcidin levels in PV can ameliorate the clinical situation significantly. And that is why a huge variety actually from different drugs is now actually tested in this setting. And the most advanced candidate is rusfertide, which is an injectable hepcidin mimetic. It has been tested in phases 1 to 3, and also in a placebo-controlled setting. And this is the data from the so-called REVIVE trial, that is the phase 2 trial, which had 3 parts. So the first part was a dose-finding part, and then there was a placebo-controlled part, and afterwards all the patients could actually receive rusfertide. 70 patients have been included in this trial, with 59 patients actually on rusfertide. And as you can see here, the hematocrit levels have been well controlled over time. Patients had started with a median hematocrit level of 50, and this went down to 44.5 over time. And this is only the placebo phase, where the placebo patients actually went up again, but then could go down again when they could receive rusfertide afterwards in the part 3. So actually the response rate was 60% on the rusfertide arm and only 17% in the placebo arm. This is also shown here on the left side. So here are the number of phlebotomies, which were in a median 8.7 for 28 weeks before starting on rusfertide, and 0.6 actually being on the drug. So there was an estimated difference of 8.1 phlebotomies per year. There was also a significant decrease in symptom scores for the rusfertide patients, and there were quite some adverse events also on rusfertide, but most of them were low grade. There were only 13% of the patients who had grade 3 adverse events and no grade 4 or 5 events. So there are also other drugs with different mechanisms behind them. So there is a monoclonal antibody, there is a ligand-conjugated antisense oligonucleotide, and there are 2 different siRNAs, which are almost working all in this kind of strategy. So this is really exciting, and we will have more data on this mechanism soon at ASH and at the other meetings. So what is the next thing? There is HDAC inhibition also in PV. How does HDAC inhibitors actually work in MPN? So they work through epigenetic regulation, by promoting gene expression, and also by targeting the JAK-STAT pathway directly with increase of SOX1 and SOX3 proteins. And we already have clinical data for this. So here we can see the 4-year follow-up data of a phase 2 trial. There actually have been 3 phase 2 trials of givinostat in PV. This one is showing the data from 51 patients who actually had benefit from the previous trial where they were introduced to givinostat, and then they could go over to some sort of long-term treatment. And as you could see, more than 80% of them could actually maintain their response, and there were also molecular responses seen even after these 4 years of pre-treatment, and there were quite a lot of patients benefiting quite a long time from this drug. Next target would be LSD1 inhibition. The rationale for that is that bomedemstat is actually selectively inhibiting proliferation and inducing apoptosis. There has been a variety of in vitro in vitro data that has been presented in the last few years. So it is able to reduce platelets, it is reducing inflammatory cytokines, and it's in mouse models, it was also able to reduce allele burden. And there has been a trial design presented in PV at ASCO 2024, but there is no clinical data available yet, and that is why I wanted to show you the clinical data from ET, which was quite impressive. So this is the data from the phase 2 trial of bomedemstat, where you could see a really significant platelet control, which was independent of driver mutation, and only by the price of only a few adverse events. But there was one adverse event that was kind of thrilling, because there was dysgeusia, I think it's pronounced. So actually patients couldn't really eat anymore, because everything, one patient told me, it was tasting like soap. So that could be a problem, but bomedemstat is currently tested in a phase 3 setting, so we will have more data on this. What was quite impressive also in the phase 2 trial, that actually 85% of the patients in this trial had a decrease in driver VAF at week 24, and that there always also was some sort of bulk sequencing, that the proportion of homozygous cells dropped by 2/3, so 66%. So the phase 3 trial in ET is actually running. There's also been data in myelofibrosis, and we are really waiting to see the results in PV as well. So is there actually anything else currently tested? And I was quite happy to see that there are now some really new approaches where we do not have clinical data yet, but I wanted to show you 3 different trial designs, which perhaps might be promising or are just new ideas which are currently tested. So the first of all, there is a combination trial testing a JAK inhibitor with a PARP inhibitor, actually in like a pan MPN trial, so it's for myelofibrosis and also for PV. The rationale for this trial is actually based on data that was shown almost 8 years ago by the group of Thomas Skorsky, because there are synergistic effects of these 2 inhibitors. So because of the double strand breaks that actually are accumulated in MPN, and ruxolitinib actually inhibiting the repair mechanisms for that, there is a synergistic combination possibility, because then actually the PARP inhibitor causes abundant accumulation of these double strand breaks, and therefore there's more apoptosis in the combination setting. And I'm really happy to see that actually this is now tested clinically, because I know quite a lot of colleagues who have actually pitched this idea to several companies during the last 8 years, and none of them was actually really wanting to try this combination. So I'm really looking forward to see what is coming out of this trial. And perhaps the combination with pacritinib is quite lucky in this setting, because a lot of the PARP inhibitors actually cause thrombocytopenia, and I think that was one of the reasons why none of the other JAK inhibitor companies wanted to try this setting. And then there is there are some candidates which we know quite well and have known for several decades, and so there is an optimal dose-finding study of N-acetylcysteine in patients with MPN, and especially with PV. So I mean that it's actually a question if that's really going to influence a progression or anything, but I think it's N-acetylcysteine. We all know that from coughs and from other diseases that we treat. It reduces inflammation, and TNF-alpha is also reduced, and there is a bunch of supportive trials running in combination here with acetylcysteine, and it's focused on the reduction of the symptom burden of the patients. So we will see what is getting out of there as well. And then last but not least, also a very old drug that we all know from other diseases is currently tested in a monocentric approach, and that is methotrexate. Methotrexate is actually widely used, is really cheap, and is actually safe. We use it a lot for arthritis and for other diseases, but it was recently identified to be a type 2 JAK inhibitor, and so now it is tested in a monocentric setting, and I think especially in case of adequate responses, this has a high potential for low-income countries, because this is a drug that is actually really available all around the globe. And so to get to a conclusion, I want just to state that there are several new targets currently tested in clinical trials in PV, and we have different approaches. Some of them are more focusing on the symptoms, but there's also some potential for influencing inflammation and perhaps thereby also progression with different pathways. And with this, I thank you for your attention, and I'm happy to take questions after the other talks. Thank you.